you've introduced a concept here at the Geriatric Oncology Conference of precision medicine. This is based on molecules. What is the big hope of looking at a genetic analysis and looking for mutations? How much better can we treat cancer, especially in older patients, by looking for molecular signatures?
So the basic idea of precision medicine, what we call personalized medicine or molecular medicine, is to define for each patient individually the molecular alteration that is implicated in the cancer progression. So this idea is to have like a molecular portrait, to define different molecular alteration, and then to find the right drug for the right patient. The goal is to try to increase the clinical benefit, to try to stabilize or to try to decrease the tumor burden. There's different examples where this kind of approach was a success. For example, with crizotinib in ALK lung cancer, or with immunotherapy in melanoma. There are some challenges because we need to perform tumor biopsy in our patients. This is not an easy thing, but we are convinced that during the time of the cancer progression, the biomarker is going to evolve. So we need to rebiopsy patients, perform analysis, and then we need to find the good drug.
Right, so what would doctors now be doing with their patients? They presumably have to have some kind of biopsy and then get a full analysis of all the mutations.
Yeah, I think until now this program is only for clinical research because we do not demonstrate that this kind of approach is better compared to standard treatment. But I think it's very good to discuss this approach with patients. Most of the time patients are very keen to participate to this clinical program. They clearly understand that if we have a biopsy with a new analysis, if we can understand better the cancer, we are maybe be able to find better drugs.
And you can have a new kind of phase 1 study, you've been saying, because some of these molecular alterations are obvious targets and they can lead to drugs which have a very big effect. How do you do these new studies? What's been happening?
Yeah, exactly. During the last 5 years, we have several examples of these mixed, what we call phase 1-2 trial. So the goal of this trial is to have safety but also activity of a drug. And this trial has been possible because we have very nice agents, very active agents. Most of the time the drug target what we call a drug oncoding, what we call an oncogene addictions. So this is not always the case, but in very nice example like in cancer, we have been able to demonstrate that when you have a cancer with ALK translocation, for example, which is a clear oncogene addiction, when you add a drug that targets this addiction, you are able to have a huge clinical benefit. So in this case, it's very difficult to perform a phase 3 trial because there is no true comparator.
So do you have, or could you get, an algorithm that tells you which drugs to use when, and when to give up the targeted approach and to use standard chemotherapy?
So we are just at the beginning of this big adventure. So there are some consensus about the targets, but this is clearly at the beginning. So I think during the next future, we are going to make progress in the understanding of cancer biology, and we are going to be able to define the good target and the, I will say, bad target.
Could you give me some examples? For instance, lung cancer has changed quite a bit, hasn't it?
Exactly. Lung cancer, the management of lung cancer patients have been revolutionized by this approach. So now in Europe, when you have a patient in your clinic with lung cancer, you ask for different molecular alteration because each alteration could be targeted by drugs, and you can individualize the treatment for each patient.
Individualizing therapy has been a holy grail. How close do you think that is right now in many cancers?
I think in some cancer we can individualize the treatment, but the deception was we are not able to cure cancer at this time because most of the time when you try to block cancer progression, after several times, the cancer are going to recur. So we cannot cure patients with this kind of approach, but we are able to stabilize or prolong the life of patients. So we need to add something with this drug.
And you can alter the sequence of drugs, because if you find a mutation, you go in first with the drug that targets that mutation.
So exactly. So the precision medicine program is very useful for, I would say, refractory patients, but it's also very useful for patients that progress after a first drug. So there are some programs now try to understand not the first molecular alteration, but try to identify the resistance mechanism. So there's like a future for precision medicine in this setting.
So what messages would you give to doctors about getting on with this precision medicine? Clearly there's a lot of studies still need to be done, but what are the simple ways forward that you can describe to doctors and the hopes that they bring?
So I think the major take message is to consider that when you see a patient in your clinic, when you see 10 different patients in the clinic, probably this patient have 10 different diseases, even if it's a lung cancer or prostate cancer. So the idea is to try to use a molecular portrait to individualize each tumor type and to try to find the best drug.
And the actual improvement could be huge.
Could be huge if there's what we call noncoding addictions.
And how many patients do have an oncogene addiction and something that really can be dramatically changed?
I think probably at this time we consider that between 20 and 30% of patients have this kind of cancer with clear oncogene addictions and could benefit of this kind of approach.
And of course, although we're talking about individual mutations, collectively there's a large number of patients with those relatively rare mutations.
Exactly, so this is the second lesson from this kind of program. If you perform molecular portraits, you are going to create like different orphan or rare disease. So there is no common cancer. This is a sum of different rare cancer.
And the final take-home message for doctors is what?
I think the final take-home message is to try to discuss this approach with patients and to refer patients to clinical trial for biopsy or for phase 1 unit.